Yay Media Group.
GLP-1s, you know them as things like Ozempic or Wegovy. They have truly, completely changed the conversation around weight. But these medications, they're not just about having someone eat less. And the reality is that with GLP-1s, nutrition matters more than ever. So in this week's episode, obesity medicine specialist, Dr. Amanda Fontenot, is joining us to talk through the benefits of these GLP-1s and things you would expect, like weight loss. But there's all these other surprising benefits beyond even weight loss that are tied in with taking these medications. We'll also be talking about the risk of these medications, the trade-offs to consider, and ultimately how to protect long-term wellness along the way. A quick note before we dive into today's podcast. If you like what you hear, I would love for you to subscribe to Fueled Wellness and Nutrition, wherever you download your podcast. It would also be incredible if you take a minute to rate and review this podcast. Those things do matter and they really help us. I'm Molly Kimball. Welcome to Fueled, a wellness and nutrition podcast. I'm a registered dietitian and nutrition journalist with a passion to help people live their strongest, healthiest life possible. In my weekly TV segments and columns, there's a limited amount of time and space to cover everything, but there's so much more to share. This podcast is my opportunity to dive deeper into the topics you want to know about. Welcome to Fueled Wellness and Nutrition. In this week's episode, we are talking about one of the biggest changes that we've seen in medicine and nutrition in decades. We are talking GLP-1 medications. Most of us know these medications by names like Ozempic or Wegovy, Mounjaro. Some of these were first developed for type 2 diabetes and then became widely used for weight loss. The conversation now is expanding even more. There's research and FDA indications connecting these medications to benefits that go far beyond that number on the scale. So we'll be looking at some of these benefits, including things like reduced cardiovascular risk, sleep apnea improvements, changing how our body handles inflammation, even affecting the reward pathways in our brains that are related not just to food cravings, but also things like substance use, alcohol use. There's so many other aspects of our behavior, our cravings that are tied in beyond just the food noise that is affected by these GLP-1s. And then there's also real considerations that we need to pay attention to. So there's things like muscle mass, there's GI issues, there's even the aesthetic changes that people talk about. You know, you'll hear people say there's Ozempic face that they get. So there's so many other considerations beyond just weight loss with these. So today's conversation, it's not are GLP-1s good or are they bad? It's how much are we understanding these? How clearly do we understand these? Making sure that they're being used and prescribed safely when appropriate, and also making sure that nutrition is part of the plan from the beginning, and keeping a close eye on mental well-being as well. So joining us today to talk through all of this is Dr. Amanda Fontenot. She's an internal medicine physician and obesity medicine specialist at Oxnard Health. Dr. Fontenot serves as the obesity medicine director. She's been deeply involved in obesity medicine, bariatric medicine, physician education, and patient care for years. She brings the clinical perspective that we're looking for this conversation. How are these medications working? Just how do they work inside of our bodies? Who are they best suited for? What benefits she's seeing in her clinic? What are the risks and the trade-offs that she's looking out for? And ultimately, how nutrition and lifestyle support can help patients do all of this as well as possible. So with that, welcome, Dr. Fontenot.
Hi, Molly. Thank you so much.
Yeah. So I would imagine your profession and your area of medicine has always been that. You know, when we look at obesity medicine, since you entered the field, it's been something that people have questions on, and you've been in these spaces that are really cutting edge in that bariatric space. And now the GLP-1s have just opened a whole door and a whole population who is considering probably that is coming to you for help who may not have come to you before.
Absolutely. So I've been doing obesity medicine about 15 years. And in the past, I'd say probably 5-6 years, the biggest thing has been, oh, I didn't know that existed. And so now it's become, sort of in the zeitgeist that people realize that there are medical treatments available for weight and for obesity, and that there are specialists in the field, that whether it's another doctor referring patients to me or whether it's someone who is seeking out help on their own, that now they have come to realize that obesity is considered a chronic disease that needs and deserves treatment, and definitely has become something that people are much more aware of, that we
And
are there to help.
And before we go too far in, we'll start with our transparency note. Since we're going to be talking about the different medication categories and brands of these and such, can you share with our listeners any of the relevant professional relationships or advisory roles that you have with these?
Yes, so I do speak on behalf of Novo Nordisk for their weight loss products, Wegovy and Saxenda, as well as for Lilly, who produces Zepbound and Foundeo. And then I'm also on the advisory board for another pharmaceutical company called Viking Pharmaceuticals that does not have a product on market currently.
So when we are looking at the big picture, if someone is maybe heard of these medications, Ozempic, Wegovy, et cetera, and they hear the GLP-1, but they're not really sure what it is, how do you explain this to someone?
So, GLP is glucagon like peptide, and these medicines that we have on market now are receptor agonist. And then, in particular, tirzepatide is a GLP and GIP, which is gastrointestinal peptide receptor agonist. So, it works on both of those. The main gist of that is we have these chemicals that we produce in our gut that were discovered quite a long time ago, because you could see that there was a response that people would have taking in sugar orally versus IV. So that was kind of what piqued the interest in them. And then it was discovered that GLP was one of those hormones that comes from the gut that seemed to decrease the appetite and also slow down the GI tract. So about 20 years ago, some smart people saw what this chemical was and actually looked in nature to the Gila monster, which is a very large reptile, that could go weeks and weeks and weeks without eating, and found a version of that chemical in the Gila monster's saliva. And that became the first GLP-1 medication, which was exenatide, in 2005. The GLP that we make as humans, we release it, and within minutes, it's diminished. It doesn't stay in our system for very long. So when they came out with exenatide, they were able to modify that peptide so that it lasted a few hours. And then a very smart scientist, Dr. Lottie Knudsen, who looked at that molecule and attached a fatty acid chain on the end, and was able to now nearly replicate GLP-1 that we produce naturally, but it could stay in your system for a day. And that was the first once daily GLP-1, which was liraglutide. And then eventually they were able to modify it in a way so that it stayed in your system for a whole week, which became semaglutide. And so, with these improvements and refinements and easier administration, these medicines were originally approved for diabetes, and then liraglutide was approved for weight loss in 2011, I believe. And then we've, of course, seen kind of the pipeline kind of ramp up from there with more medications. And they've been available mostly in injectable form because if you take them in by mouth, your stomach acid breaks them down. And now they've kind of overcome some of those barriers by making some alterations. Or most recently, there's a small molecule GLP-1, so it's not a peptide. So that makes it more stable and, in theory, cheaper to produce. And so we've just seen kind of all these refinements along the way. And I know we'll talk later about some of the different ones that are being developed. But it's been quite an exciting ramp up, over these years, that we've seen sort of this progression from a medicine that was kind of cumbersome, had to be
Right.
taken twice a day as a shot, to once a week injections. And now, for people who don't want to take a shot, there's daily pills. But what they're doing is using this gut brain axis, because this GLP and GIP hormones are from the gut, but they go back up to your brain because most of your appetite is controlled in your brain. And so then that's where you get the decreases in the appetite and cravings and possibility of maybe helping with some other conditions. And so it's really that connection between these gut hormones feeding back up to the brain is what we're using to work on weight loss.
That brings me to the next, for me, it's a really big question. Do we know the mechanism of action? Do we know how these are working? We know there's communications along that gut brain axis. We know there's messaging of what our the messaging from our brain that's looking at appetite and turning down that food noise for people, and having the successful reduction in appetite and cravings and intake. Do we know how, like what the actual, like what's actually happening that's making that, leading to that result?
Yeah, so I think for weight loss, we have a pretty good handle on how and why the medicine works, because we know in certain parts of your brain, the amygdala, excuse me, the different areas of the brain that regulate the appetite is where these receptors are working. And so in previous weight loss medications that we've used, they also work in the brain, but at different receptors. So this is a different approach to it. And we also know that those same chemicals, GIP, GLP, and a few different ones, also during after weight loss surgery, when people have bariatric surgery, those levels also go up.
Right, right.
And so we know, from historically people having surgeries for weight loss, that those hormones kind of affect those things as well.
Are there other, tell me more about kind of the receptors in the brain that are affected by the GLP-1s. Are they what we think of as sort of some of the um, that reward circuitry, or that those pleasure centers that are, or are they strictly appetite related? I guess what I'm getting at is part of what some of the reports are that I've read on GLP-1s is that the cravings or the compulsion that someone feels is reduced, and sometimes not just for food, but they also may have lower cravings for alcohol, any of those other things that are sort of a vice. It can sort of dampen the craving for those things even beyond food. So tell us more about those areas of the brain that are impacted and how that can have these other benefits or other effects.
You work hard to keep your family healthy. You eat clean, stay active, ask questions, and want the freedom to make the best decisions for their healthcare. So why does the traditional system still feel so expensive and disconnected from actual care? Crowd Health is different. Built for families, entrepreneurs, and independent-minded people, Crowd Health is a community of more than 28,000 members helping fund each other's medical bills directly without restrictive networks or corporate middlemen standing in the way. Over 40,000 medical bills have already been funded. It's not health insurance. It's a simpler, more human way to pay for healthcare. You choose any doctor you want. Plus, a dedicated care advocate helps you navigate every step of the way. Because communities take better care of each other than corporations do. If you've ever felt frustrated with the traditional system, it's time to see why thousands of people are choosing something different. Learn more at joincrowdhealth.com. That's joincrowdhealth.com.
So absolutely. So those same parts of the brain that control your appetite typically are also associated with things like alcohol, drugs. And that's one of the ways that I'll explain it to people. When you eat like highly palatable, highly craveable foods, if someone scans your brain in that moment when you're having that kind of reaction to it, it's going to look a lot like being on a drug or being on alcohol, because it's all in the same parts of the brain. So there are lots of studies now that are looking at these types of medications in terms of substance use disorders,
Right.
and things like that, that does appear, those studies might not be completed as of yet, but it does appear very promising in terms of helping possibly some types of substance use disorders like alcoholism or drug abuse,
Right.
because all those parts of your brain work together. Like they're all very much the same. Yeah, it's all happening in the same place. Beyond so with something like alcohol, beyond the feeling bad, and then there's the calorie intake with
Right.
it. You have poor impulse control, so then maybe you're not eating as well. And then
Right.
fat is burned off at the same place as alcohol. And your body knows it has to move out the alcohol because it's a toxin. So it turns off burning fat. So in that sense, it's very much often related to the weight problem as well. And then I've even had a patient tell me she had had a compulsive shopping problem. And when she started on a GLP, she stopped shopping so much.
Right. Right.
She
I've
felt
I've
like
read this about
even
gambling.
addictive type behaviors,
Y-
seem to kind of improve to
Right.
some degree.
And I think it's exactly that. Shopping is one that I hadn't thought of, but you're right.
Mhm.
Like gambling, drinking,
Yeah,
drugs, all of these. So to turn down that drive for whatever that vice is that someone has is really, to me, that's a really interesting part that we're learning more and more about
Mhm.
the effect of these GLP-1s. On the flip side, what I've also read some reports, and have you heard this from patients, is there's a drop in the pleasure they're experiencing in life in general, that maybe that feels a little muted because they aren't having maybe that rush that they had from some of these things. But then they may feel that they're operating just on a little bit lower key.
Absolutely. And we see that sometimes after weight loss surgery as well. We don't know exactly. Is it from diminishing some of those brain reactions and chemicals? Is it possibly because food for people is very complex? We eat for a lot of different reasons. And so people eat to celebrate, they eat to cope with stress, they eat when you're sad, when you're happy, and different people, different ways of doing things. So we don't always know, is it because of that brain part of things? Is it because of coping? Is this because, sometimes we do see with substance abuse, people get off of one substance and then they need something else to kind of
Right.
make up for it. Is it that kind of drive? So that part, it gets complicated, and it's hard to say because we're humans and we're complicated. And so,
Right.
yeah, we do hear people say that, like that, without that part of life that they had placed on food, that then something is different or lacking. And that is a real thing. And that's where mental health comes a lot into play, with helping the person maybe to adjust, as far as we want you to enjoy life. I want my patients to enjoy their lives, their celebrations, their vacations, but maybe we have to work on a different way of enjoying it. That strong drive or that strong response with food, it is a little different, because when you think of someone, if they smoke, if they drink, if it's a drug, you could go your whole life. You don't have to drink alcohol. You don't have to pick up a cigarette, but we have to eat. And so when there is that strong drive for food or strong response to food, and then I also tell people, food companies engineer the
Oh,
food
gosh. Yeah.
to give you that response. And I try to tell people that and tell them about how it lights up their brain and all of that, because my feeling when I learned that was, well, I'm not going to be anyone's patsy. Like
Right.
I refuse. Like, I'm not going to eat that because you are designing it to hook me on it. And I don't appreciate, like, I'm not going to
I'm not going to be
participate.
manipulated. Right.
Right. I'm gonna be aware of it, and that, I
Yeah.
think, does help a lot of people to realize, while we're all wired differently, and there certainly be people who are very wired, sometimes even to the point of there are certain genetic disorders, to respond so strongly to food, or someone like your husband who has, this is just fuel to get me through the day, and my stomach was growling. And there are people who maybe feel fullness very strongly, and some people who don't have that off switch. and just becoming aware of like, what's your wiring?
Right.
What are your effects from different things? And knowing for a lot of people that that's what they need and have to do can be empowering to then like take steps to be aware of it and maybe make some changes accordingly.
With the GLP-1s, these are some of the other kind of surprising benefits that have come from it. But what are some of the others that are beyond weight loss that are real strong benefits that you're seeing with this and that research is showing us?
Well, certainly one of the biggest ones is one of the weight loss drugs, semaglutide, has been found to have like a 20% reduction in recurrence of cardiac events in people who have had heart attacks or strokes or amputations. And we're not sure why that is, because the weight loss in that study, the study was done for heart disease. It was not done for weight loss. And so the people didn't really get specific weight loss instructions. They didn't lose a lot of weight as we see in the weight loss studies, but they still got these tremendous cardiac benefits. And that is one where we're like, we don't know why, but it's working and it is a huge reduction for those patients. There's been shown to have a good chance of improving sleep apnea, possibly even to resolving sleep apnea, which is a very tough medical problem to address. And then fatty liver disease or metabolic associated steatohepatitis, MASH, has been shown to improve with these medications, which there's only 2 medications approved for that disease, and one of them is a GLP-1. And so we are seeing tremendous benefits. And now when they're doing a lot of the drug trials, they are including, looking at how they affect certain medical problems. So one drug that's in trials right now, retatrutide, has shown tremendous weight loss, but also improvement in osteoarthritis symptoms. And it's thought that there may be some inflammatory benefits with these medications. And, heart failure has been studied with some of them, and it appears to improve hospitalizations and symptoms in heart failure. And so, kind of looking at these other benefits, also because we can say all day, well, yes, losing weight makes you healthier. And I think most people are on board with that. But being able to really, in randomized clinical trials, show that improvement, real data, real numbers about it, has definitely been a shift in the past 10 years or so that we've been able to see. And so that is also really exciting. And then looking at things like substance use disorder and
Right.
different things like that, possible cancer benefits. So lots of those things are in trials right now.
Then on the flip side, I think we all probably can think of at least one person we know who has very little, not what someone would consider obese. It might be just those extra couple of pounds that they're uncomfortable with, but medically, clinically, those aren't causing any issues. So what is your thoughts, or what is the medical community's approach with someone who is coming in seeking GLP-1s for that, 10, 15, maybe 20 pounds?
So for me, it's kind of easy because that person wouldn't make it into my clinic. Being that I just treat weight, we screen patients. And if they do not meet the FDA approved criteria, we will call them and tell them, we're not going to see them. Of course, for just, in primary care, which my background is primary care as well, that can be a little tougher because you're talking to patients of all different shapes, sizes, everything all throughout your day. So for those patients who don't meet the FDA criteria, which for all these medications is a BMI 27 to 30 with some kind of weight-related medical condition, or 30 and higher, regardless of weight-related conditions. I think it's just important to stand by that and tell the patient, these are the FDA criteria, because that's where we know people are getting a benefit that is worth the risk.
Mm-hmm.
Because we, don't know if the risk of the medication, because every medicine has side effects, every medication has risk, that if that is worth 5 or 10 pounds, and can they work with a dietitian? Are they doing
Right.
those things on a day-to-day basis as far as physical activity, what have you? Is there some area of the life where they can use counseling to help with maybe if something is triggering different eating behaviors or whatnot? Because we do want to stay ahead of it. We want to keep people from becoming eligible for the weight loss
Right.
medication, but we have to do it in the lowest risk way that
Right.
you can. And so, medicines are not going to be for everyone. And that's also part of just responsibly keeping healthcare costs down, things like that. But offering that patient some other avenue to work on those few pounds that they feel like, is affecting them.
So when we talk about the risk, in line with that, because I think I think that's a really strong conversation of, I think about people who, we have the conversations in my head that I've had with people, and they'll say, and clearly this person maybe had 8 pounds to lose, 10
Mhm.
pounds. And they'll say, well, I went to see someone who prescribes GLP-1s, and, I'm at risk for borderline hypertension. Well, you don't even have hypertension, and you don't even have borderline hypertension. You're at risk that maybe one day you're going to have it, but they're sort of edging around it with a little bit of a justification with those types of conversations. I'm like, but you didn't really need it. So for someone like that who's tossing it around because it seems like a simple fix for something maybe that they're struggling with, but they don't have all these other risks. When we talk about the risk and trade-offs, what are some of those for people as they're considering these?
So most of the risks or side effects with the GLP-1s are gastrointestinal related side effects. So nausea, vomiting, diarrhea, constipation, GERD or reflux, abdominal pain or distension. Those would be the most common ones. And those do run in rates of like 20+% depending on the medication. Now, that being said, that's that side effect occurring at all. It doesn't mean that it happens all day, every day, the whole time the person's on the medicine. The most common times for that to happen will be when a person first starts, or if you go up on the dose, those side effects become more common. But it's not going to be like a day-to-day thing for the whole duration of treatment in most cases.
Okay.
If that's the case, then they may not be someone who tolerates it, because
Okay.
that wouldn't be, really normal to have that all the time. And those would be the more common ones and not really considered serious, adverse effects. The more serious effects are more rare. Things like pancreatitis or gallbladder disease or things like that. Those would be some of the more serious things that could happen. Or, of course, you could always be allergic to something and have a serious reaction or what have you. Those are more rare, like probably occurring 1 or 2% more than they did in the placebo group of the trial. So
Mm-hmm.
people weren't really getting medication, and that's something people should be aware of, and that providers should be aware of if they're writing the medications, should they come up.
Mm-hmm. Okay.
Then, like you mentioned earlier, Ozempic face or different things like that. Things that have come up with those types of situations really are just effects of losing a good amount of weight. So, skin sagging, loss of the facial fat that keeps the face kind of lifted and full, or sometimes Ozempic butt has come up, same type of thing. Those are side effects of like dramatic weight loss. And so it wouldn't matter how it happened. It's not specific to the medications, but seeing people lose that type of weight, 30, 40, 50 pounds certainly could happen. And the other one that comes up that makes a difference to a lot of people, it's a very sensitive area, is hair loss.
Yeah.
Um,
Okay.
and so that is something that is something you can see in significant weight loss or rapid weight loss. Hair loss was always known to be a side effect of rapid weight loss, but it is occurring at a higher rate with these medications than we would expect just related to the weight loss. So then I do tell people, if it is really bothersome to you, to know if it's an effect of just the medicine or not, you have to come off of it, or they can do things to kind of counter the hair loss, certainly nutrition wise, using things like minoxidil. That is a risk versus benefit, but particularly for a lot of women, that can be a side effect that they really do take notice of. And it is
Right.
certainly a possibility. And we're
Right.
seeing on the new medications that it's listed more often, maybe because it's occurring more, but also because I think it's something we've become more aware of as
Mm-hmm.
using in clinical practice. And then there's another weird side effect that everyone's becoming more aware of and is coming out more in studies called dyesthesia, which is a weird sort of sunburny or pins and needle kind of sensation in the skin. And again, it probably was happening early on, but maybe people weren't as aware of it. And now that they are, it's asked about. And so it's coming out at higher rates in the studies being done now. And that's something that usually can be with adjusting dosing or things like that can be taken care of. So again, these aren't all things that are all the time or every day, but they are things to be aware of so you can let your doctor know if you're taking one of these medicines, or if you're a provider, asking patients, how things are going with them. And then one big one that has changed as of lately is warnings about depression and suicide, is that it does not seem to be such a prevalent effect. And so there actually has been some changing in the labeling that may be happening on these products that the FDA requested, because there does not appear to be such a strong relationship between depression or suicidality as had previously been thought.
So all of this is, as we were saying, where that severity is and weight, obesity, and someone's sense of maybe, that again, that food noise or that compulsion, wherever someone's falling on that scale, really talking with your provider in detail about the potential benefit and the potential need for this versus those risks, those trade offs. And so, really having that awareness of all aspects of this. And I think you're right, hearing those other side effects that may be less common, the sensation in the skin, for example. Someone may not realize that, or even someone's provider may not be as familiar with that as a side effect if it's not something they're dealing with GLP-1s often. So, having that awareness, I think, is good to tie those all together. In that same conversation, I think about, side effects is muscle loss. Let's talk about that a bit.
Yeah, so muscle loss, again, with significant weight loss or with rapid weight loss, we've always known that that could be an issue. And so, again, taking steps to stay ahead of it. So, making sure people get adequate protein intake, making sure that people are not just eating less. The goal is not to make people not eat or to, just have small amounts of sort of junkier kind of foods. They really need to eat less and eat better so that their nutritional needs are met. And then also, as far as lifestyle and physical activity, certainly incorporating exercise, but particularly resistance training, which I am a big harp on it all the time, because it's much easier to protect the muscle mass than try to gain it back. I will say in my clinic, because we do body composition each visit, I see less than that. And I usually hold very firmly to no more than 1 pound of muscle for every 4 pounds of fat. So it's hard to say what's happening in the real world versus
Right.
what's happening in the studies. But if you look at the untreated patients who have just been doing lifestyle changes, the proportions of what they're losing in the lean and fat mass is very similar. It's just not as big of a magnitude. And where that really makes a difference is when you have someone who's coming in without a good amount of muscle mass already, and they just didn't have it to spare to start.
Right.
So again, fortunately for me, I can go over that with a person and sort of show them on a graph, you don't have any muscle to spare here. And when we start losing muscle, usually it correlates pretty closely as well with losing bone. And given that the highest proportion of people who seek out treatment for their weight are women around middle age, that can also become significant. So counseling the patient on, we need to preserve this muscle. One, it keeps your metabolism up. So that's going to help you to keep the weight off long term. And two, it's going to protect your bone health, to really get them motivated to take the proper steps, nutrition wise, exercise wise, to offset a lot of that. And there was seen in the big trial for heart disease for semaglutide, which is called the SELECT trial, there was a higher rate of hip fracture in women who were 75 and older, because that was an older group of patients. And that's also something to really be aware of, because hip fractures in that population can be very devastating.
And when you, oh, go ahead, sorry.
Yeah, and so you do want to make sure you are, for that particular patient group, being aware of issues with bone mass or osteoporosis or things like that for those patients who are a bit older.
I think for people taking it, we think maintain that muscle mass. And when we say valuable muscle mass, we're not just saying that. It is very valuable. It's the aesthetics is what someone may see. They can see that, gosh, I'm losing my muscles. But like you said, it can also affect our bone density. Our risk of falls goes up. Our mobility, how easy it is for us to move around. There's the sarcopenia as we age is a problem anyway. With muscle loss is going to happen as we age. Take weight loss, take GLP-1s out of it as we get older. Unless we're doing something proactive, we're going to be losing that muscle mass. So with something like GLP-1s, we have to be really proactive. Like you said, adding in that strength training, encouraging patients, if you're the patient taking it, doing this on the regular and at least 3 days a week, strength training. And then also from the nutritional perspective, making sure you're prioritizing that protein. And so if, I find, you mentioned kind of nausea being one of the side effects. And one of the things that I've heard people say is when they are kind of feeling maybe a little nauseous or queasy, they're reaching for things that are maybe more carby. They're looking for things like crackers or pretzels or stuff like that. So if that is something that someone listening that's sort of, you're like, yeah, that's me. When I'm not feeling good, I reach for those things. There's now on the market, there's so many different protein filled versions, for better or for worse. You can get a protein Pop-Tart. It's like you can get protein candy, protein anything, and it's sort of a for better or for worse. But there are different things that are protein pretzels that they'll have at Costco, higher protein granola, higher protein cereals that are also natural without a lot of other synthetic dyes or artificial sweeteners. So if you can find different crackers or pretzels, or there's protein bagels, there's so many things that can give you that maybe bready feel that is what feels like if you're nauseous, that's what you're reaching for, but you can kind of sneak in some of that protein to keep it a priority as well.
Well, and I'll tell you, Molly, so one thing people may not realize on these medications, the way you eat can really influence those side effects like nausea and diarrhea and constipation. So sometimes if people go too long without eating, they will actually be more nauseous. And so, kind of feeling like it's a little against what you would normally do. Sometimes when you're nauseous, it's because you actually need it to eat.
Right.
And so if they can get on that steady routine, protein and fiber in every meal 3 to 4 times a day, because it's going to be a small amount because they get full quickly. Drinking enough water, all of those are things that are helpful to lose weight. They're helpful for your muscle mass. All those things kind of go together, and they also help decrease a lot of the side effects that people feel with the medication. And so it actually is helpful to make sure you get that adequate protein, adequate calorie intake to keep the side effects at a minimum as well.
And you said protein, fiber, hydration are some of the key things that every time you're eating. And that fiber can come from vegetables. It could come from whole grains or beans or any of these things. And making sure you're layering that protein source in every time. It could be cottage cheese, Greek yogurt, eggs. There's so many different options of what you can reach for, but make sure that you're factoring those in and thinking what's giving me my protein, what's giving me my fiber, and making sure that we're staying hydrated. Smoothies can also be a great fit for that as well. Now with smoothies, you've got to be real careful because a lot of smoothies can still be really high in sugar. So making sure that if you are reaching for a smoothie, it's one that's high protein, low sugar.
Yes, absolutely.
We'll give a plug. Actually, we worked with. I think we had interviewed you, put a survey out to you with some of the other providers when we worked with Smoothie King. We have some Eat Fit approved smoothies that they've designed specifically for people with taking GLP-1s. And so, if you go to Smoothie King, you'll see, or if you look at the Eat Fit app, you'll see the list of all the smoothies that Smoothie King has specifically designed for people on GLP-1s. And what we looked at there was, how can we squeeze in that protein? How can we keep sugars and added sugars close to zero and even sugars total low? And then how can we also squeeze in extra nutrients, extra vitamins, minerals, vegetables that are going to be squeezed into these? So plug for those GLP-1 smoothies at Smoothie King. On the note too of micronutrients, so vitamins, minerals, what are some of the keys here that you would say really keep an eye on for someone taking GLP-1s?
So my biggest push would be having a, balanced whole food diet is the first line of defense there. Certainly, though, the quantity of food is going to go down. Now, that being said, some people may be having excess calorie intake, but they don't have the best diet. You could still run into nutrient deficiencies in that case. And so working on, again, the eating better, getting in your vegetables, your grains, your lean proteins, that's the first line of defense. For someone who is taking a GLP-1 medication, not that they've had weight loss surgery or other things like that, or have known vitamin deficiencies, just your average person on the street taking a GLP-1 medication, if they want to do an adult multivitamin, daily, just to make sure they're covering their bases, that's totally fine. If they want to do a fiber supplement to help with the issues like constipation, totally fine, as long as they pair it up with plenty of water. Totally fine and reasonable. But we don't want to overshoot just day-to-day taking extra vitamins, because if you have a good diet, you don't necessarily need them. And there can be some poorer outcomes with too many vitamins. Plus, you're just kind of at that point wasting them, and you're literally going to send them down the toilet. So we don't need to overdo it. But I think a daily multivitamin is totally reasonable. Making sure that people do get, their omega-3s, whether it is from some type of fatty fish or shrimp, or if you want to get omega-3 eggs and enjoy the yolks and you don't have to feel bad about it. All of those things that can help them to make sure they're getting like some of those essentials in. But most of it being from the diet, not overly relying on a lot of supplementation that's not necessarily been proven to give the same kind of benefits.
And that multivitamin just in general can be, while it's just insurance, for most people, it's not going to do something that's going to markedly improve wellness or longevity for most people, but it can be that nutritional insurance that we don't have deficiencies there. What do you have a level that you recommend for people on GLP-1s to aim for in terms of protein?
So what I use, if we have body composition, what I'll do is 1 gram of protein per pound of muscle mass, and then just kind of round it up. So if someone has 60 pounds of muscle, then I'll tell them, make sure you're getting around 70 grams of protein a day, to at least maintain that muscle mass. If we don't have body composition, a kind of easy way to figure that out would be, what is the goal weight? So let's say a person wants to get to 150 pounds, then divide that by 2, and that's your grams of protein per day.
And that would
And
be
so
a minimum, you would
about
say,
75 for that person. And
as a
so
minimum.
as a minimum,
Yeah.
yeah. But then I also do caution people because, everything in the media now is protein, protein, protein.
So still from a looking at general population, half of your body weight, if you're looking at what someone's healthy body weight is, taking half of that is still pretty low as a goal for protein. But there's two things there. That's the minimum.
Mhm.
And like you said, they're already going to have a reduction in appetite. And
Mm.
so we're working with a lower intake of food and keeping that as your minimum. So basically half of a gram of protein per pound of healthy or goal body weight as a minimum baseline. And more isn't always better because if someone is just doing way high quantities of protein, then we can easily also have excess calories. But I do think that just my conversations with people, which is not nearly like yours, of course, but the off the cuff conversations that people share, protein does seem like the biggest challenge for them to get. So it seems like people are not usually at risk of the too much. And then in working with a registered dietitian. And so in clinics like Dr. Fontenot's clinic, y'all have dietitians looped in already in the work with many of your patients. But depending on the type of a provider that someone may be getting their prescription, their GLP-1 from, they may not be connecting them with the dietitian. So if that's the case, seeking out the advice of a registered dietitian to, just like Dr. Fontenot said, we're talking in these numbers, but how does that translate into actual food choices for you? And so working with that expert dietitian who can guide you there. What are some of the labs or markers for someone to ask about as well? So one, working with a dietitian, if you could ask for a consult for a dietitian to see if insurance covers that. But then what are other things for them to keep an eye on, or is there certain labs or markers for people to watch?
So there's really not routine lab monitoring for any of the GLPs. And so it's not a routine thing. Typically, we do want to look at some kind of baseline, which people may be getting, their yearly checkup. So their basic, chemistry panel with their blood sugar, their kidney function, liver function. Sometimes those things are also just for us to look to see, are there any weight related issues that you might have that maybe we haven't been aware of or that can be improved. So are you in that pre-diabetic range, which also incidentally makes it harder to lose weight? Do you have signs of some kind of liver dysfunction that we might need to do some more testing or screening for, because that's something that could become very serious down the line. So a lot of looking at the labs, is there some other reason like thyroid dysfunction that you might be having a hard time with weight? But a lot of looking at the labs is really more to establish where this person's risk from their weight might be, or if they're having complications from the weight, and then tracking those as they might improve, and often do really, really improve on the medication. But as far as related to just taking the medicine, they really have fairly few contraindications. So even if someone has liver disease or kidney disease, they typically are still safe to
Okay.
use. And they don't show a lot of issues as far as causing a lot of problems that you'd need lab monitoring for. There are some specific situations where, like, if someone's on multiple blood sugaring, lowering medications, that then we might need to keep an eye on their blood sugar or adjust some medications. Again, those most common side effects are GI. So if a person is having a lot of nausea or diarrhea or vomiting, do we need to check some labs? If those things come up, that they might be dehydrated, or do we need to check to see if there's something with the pancreas or with the gallbladder that could be happening? So if those things come up, of course, we might need to do some more workup, but there's really not a routine, lab panel associated with taking the medication.
And for someone who starts these, they're seeing, great success. They're having that the benefit that they were looking for in terms of weight loss. What happens when they stop taking the medications?
So unfortunately, Obesity is a chronic medical condition. It's a relapsing chronic disease. And so we do know if people come off of these medicines too soon, they will tend to gain the weight back. Now, you can always gain weight back no matter how you lose it. So that's something that we do have to, stay aware of, and doing those long-term things to increase the chances of success. Now, how soon is too soon? There have been studies of both semaglutide and tirzepatide that have shown, those studies were STEP 4 and SURMOUNT 4, but have shown that if people take the medicine for, say, 9 months or so, they get down in their weight and then they come off of it. And these are people who were receiving an injection. They didn't know that it wasn't medicine. They were still doing all of the same things. Then the weight creeps up. Probably about 80% of it will be regained, in the next 12 to 18 months.
Wow. That's so discouraging for people.
Well, true. But, I think if you know what you're getting into and what you're signing up for. So I always tell people, based on the data we have now, that plan for at least 2 years of taking the medication. Could it be that you need the medicine longer? Sure, it might be, because there are just some people who are going to need more help than others. But plan for at least 2 years, because we know that before that is too soon. There's still longer term studies being done that will have more information during that time. But just know it's not going to be like, 6 months and I can stop.
Right.
Because then you'll losing and gaining, losing and gaining. I would rather you just stay the same instead of going up and down, And then we have had studies just recently come out that are looking at options for, could you switch to an oral medication and maintain? Could you switch to a lower dose of medication and maintain? And that's always kind of been my practice is, we slowly start taking away the medication. We add in a little bit of calories, and we see along the way, like, what's a good point for maintaining? Because the maintaining is the very hard part.
Right.
The losing is not always the hardest part. The maintaining is really where, that's the tough part, and keeping it off long term. So we do it in kind of a stepwise process and see, like, what's the sweet spot. But I will say, for most people, unless it is an issue of insurance coverage or something like that comes into play, not a lot of people are they're not rushing to come off the medicine because they feel good. They are happy. They're not kind of like white knuckling and stick to what they need to stick to.
What about compounded versions, compound pharmacies that are making these, or people who are buying the maybe like isolated ingredients online and using that? Like, what is the take on that or the guidance on that?
So currently, I think as of May 2025, the FDA said there's not a shortage of these medications. They would be off the shortage list, which technically they should not be being compounded. So that's one concern, is that per FDA rules, is not something that should be happening. And so then you have to wonder, are we putting people in a position where then that's going to go away? And also in a position where on the FDA's website, it says these compounded medicines are not tested rigorously for safety or effectiveness. And it has been shown that they can really vary in terms of how much people are getting. When people start mixing things up themselves or, adjusting things kind of on their own, there's been reports of adverse events because of that. So safety-wise, I do not recommend them. And then the cost of the medications have come down to a degree that it kind of has closed some of that gap in terms of cost. And then now we also have some oral medicines that have come out, and those are even a little bit less, starting at like $150 a month and then a maximum of $300 a month. And so those have presented also a little bit reduction in cost. So I tell people,
so you're not having to do like the underground online raw
No,
ingredient. You're mixing it
and
up
I
in your
always just
kitchen.
tell people, would you do that for any of your other medicines?
Right. Right.
Like
Right.
it's just kind of when you think about it, it is a little scary that people can go out and buy these unregulated
Yes.
products, and that it had happened in such a big way, particular to a weight loss medication.
Yes.
People with obesity can be a very vulnerable
Yes.
population in terms of, they've been sold so many supplements and programs and, products and all these things for many, many decades related to weight. It's not a new thing.
Right.
And so to allow that for this particular class of medications, I think is also kind of problematic.
Agreed completely. And there's a very big difference between, the skincare eye cream that someone may be falling prey to on social media that, ooh, this is going to solve everything versus something that you're injecting. And
Yeah.
that's just a whole different level. Agreed. Um, Anything, you mentioned the oral medications, the oral versions. Is there anything else to share that's sort of up and coming in this space right now?
So many things. I think to date, there are about 12 to 14 different medications, either in phase 2 or phase 3 trials, which means they're testing them in humans, either to set up moving forward with better refined studies or to get them actually FDA approved, depending if they're phase 2 or 3.
When it comes to both the providers and also patients, is there something that you wish providers slash prescribers, more of them were asking their patients before starting?
So, yes, I think first establishing what people's expectations are and giving them the perspective of what they really should expect. So, if someone tells me they want to lose 100 pounds, I have to tell them, even though the medicines we have today are great, that probably will not be the expected outcome. So, do we need to talk about bariatric surgery? Do we need to talk about what will help you to get there, or do we need to adjust those expectations? So, I think starting out with really clear expectations of what these medicines can do, and also what you need to do along with them. And I totally understand it can be hard to counsel a lot on nutrition or exercise in the office or even being comfortable doing that. But finding the resources to offer the patient or gather, I always, try to, whenever possible, share some of the resources I have from our dietitians that they've developed for me, or things that make it quick and easy for like in a primary care setting or what have you to address some of those things and for the patient to constantly be learning. It is a
Mm-hmm.
constant learning
Right.
process. And I think that's another expectation of just like, this is not going to be a fixed overnight type of thing. And again, could that come off as discouraging? Maybe, but
But it's realistic.
hopefully more in the sense that it can be empowering. Like,
Yeah.
okay, now I know long term, this is what I'm going to have to do. I'm going to have to build up my exercise. I'm going to have to change some of my habits. I'm going to have to look at things a little bit differently in terms of maybe my social life or relationships or things like that. Empowering the person to really move forward and making those changes and knowing that that is what really is going to make everything work. It's not just a matter of taking a pill or a shot or getting a procedure. It is a matter of doing all of those things that are pretty consistent. No matter how people lose weight, those things are pretty consistent. So I always say treating obesity happens in layers, so we're always building layer upon layer and keeping everything as we move along. We never kind of lose one thing. We're always keeping those things. Addressing mental health is a big, big part of it. And so, again, being ready with resources, whether it's an employee assistance program or insurance network or whatever, that patient might have access to. But mental health is also a big part of it and addressing, some of the issues that just losing weight won't fix.
Is there anything that is sort of top of mind that you're sharing with patients often or colleagues often that we haven't talked about that we need to share here? I feel like we've covered a lot, but if there's anything else that's sort of pressing that we need to talk through.
We have covered a lot. So I think one is just the open, honest communication. If you're the patient, really being honest about, what's going on with you, not being embarrassed about it. Doctors hear a lot of things, and providers hear a lot of things. You're not the only person going to McDonald's for breakfast. You can go ahead and say that. Really having that open, honest communication. And on the provider end, having some understanding of those things, and that, we really have to stop passing judgment on people because of their weight. You can walk in the room and see someone and they weigh 250 pounds. Maybe they once weighed 350 pounds. Maybe they once weighed 150 pounds. Until you sit down and talk to that person about where they're at and what's going on with them, and thinking about the physiology that's behind it and everything else, you really have to take that information in before you decide on how to work with them best to address it. So, looking at a person's weight, whether it's your own weight or whether you're the provider talking to someone, keep in mind a person's weight has very little to do about their whole story as a person. This is one aspect of life. It can be a very fretful area to talk about and discuss, but everyone really needs to realize it is a small part, and we want to help address it, not judge it. And if you're the patient, don't judge yourself, because these are things, so much of it is beyond our control. There are things to help. There are things to help you with the things that you may have some control over. And everyone is kind of working in a place where there are a lot of barriers as far as our food systems, our lifestyles, the way we live. All of that comes into play. So we really just have to start having some open, honest, non-judgmental conversations on both ends.
I think that's such a lovely way to wrap it up too, because it really does come down to that. There's so much working against us that is largely, a lot of it is out of our control. Like you said, the food industry, I'll use the word manipulating, the foods and finding the bliss point that lights up those receptors in our brains. And when we have that judgment on ourselves, or we're beating ourselves up because we feel like, why do I not have the willpower that I quote should, and things, there's so many things that it isn't just about setting our mind and then doing it. It can be so much more. And like you said, so many barriers to that. So I think having that pep talk for ourselves, for the people in our lives, is key. So thank you so much, Dr. Fontenot, for taking the time and walking us through all this. I know it's definitely shed light on aspects of it that I had some familiarity with, but didn't have a deeper understanding. And so I know for our listeners too, it's been a wealth of knowledge. So thank you so much.
Oh, thank you so much for inviting me.
So a tremendous thank you to Dr. Fontenot for carving out the time, spending this time with us, talking through it in a way that is practical and it's also clinically grounded. And from this, one of my biggest takeaways is that GLP-1s, they're powerful tools. And we know that from a weight loss perspective. And for many people, they can be just truly life-changing. And when we look at not just their effect on weight, but their effect on these other vices that may have had that strong grip on us for so many years, and that for some can be kind of an unexpected side benefit of these. And so for me, that's been something that looking at these over the years with a bit of a cautious eye, and, as they've been so new and relatively new in the scope of things, just having that a little bit of a concern of the exuberance and the race of so many people to try these medications, but then to also see all these unexpected side benefits that have, along with weight, these other issues that have been such a struggle for people over the years. So for me, the fact that these GLP-1s can have benefit in these areas is, again, truly life-changing for so many people. And again, the goal with this, it's not just about weight loss. It's about protecting and preserving that long-term health, our strength, our mobility, that quality of life for the long run. So for anyone listening who's either currently taking GLP-1s or thinking about starting taking GLP-1s, or if you're supporting someone who is, please make sure that you're working with a quality medical provider. Ask for nutrition support early. Don't wait until you're struggling with these challenges and then try to race to catch up with it. Starting in advance for that strength training, like Dr. Fontenot said, making sure you're getting enough protein in, making sure you have the social support, and also preparing yourself if there are any changes kind of in that mental well-being. So making sure you're giving it that thoughtful care from the beginning. As always, this conversation is for education here on this podcast platform. It doesn't replace medical advice from your own provider. And your medical history, your medications, your labs, symptoms, goals, all of that ties together to tell the picture, the story that matters for you personally. So we'll include the links that we talked about in the show notes of this episode. I am registered dietitian Molly Kimball, and you've been listening to Fueled Wellness and Nutrition, the podcast. If you'd like more Fueled Wellness and Nutrition, please head over to mollykimball.com, and you can follow me, Molly Kimball RD, on Instagram, Facebook, and Twitter. And if you haven't yet, please go to Apple Podcasts and subscribe, rate, and review this podcast. Join us next time for another dose of Fueled Wellness and Nutrition. Thanks for listening, and stay focused on living your strongest, healthiest life.
You work hard to stay healthy and want the freedom to make the best decisions for yourself and your family. So why does healthcare still feel expensive and frustrating? Crowd Health is a different approach, built for entrepreneurs, families, and independent-minded people who want a simpler way to pay for healthcare. More than 28,000 members have already joined, and over 40,000 medical bills have already been funded. No restrictive networks, no corporate middlemen, just real people helping each other. Learn more at joincrowdhealth.com. That's joincrowdhealth.com.